Thanks very much, Greg, for this nice introduction. Ladies and gentlemen, thank you very much for the invitation to talk here. I think this is an excellent center and an excellent research group, and it's really a pleasure to be here. You know, pediatricians are actually an extremely negligible species in pediatric respiratory research until about, I would say, 20 years ago or 10 years ago, when people started to realize that actually a lot of the processes that are forming asthma have to do with lung development and early life factors. And suddenly pediatricians became more important, and I would like to talk a little bit about this field. And the field is huge, is really huge, and I have actually also a presentation on this topic on Friday, and I will focus today a little bit on trajectories and maybe how we can influence them. And on Friday, I would like to talk a little bit more about, you know, models of how we can understand the complexity of all these involved factors. Now, how did this whole story actually start? How did we actually understand why infancy and the pre- and postnatal phase has such an important impact on asthma? There have been a lot of retrospective studies on the relationship between early childhood wheezing disorders and later asthma and COPD, but there have also recently been very good longitudinal studies showing some connection between these two time periods. And I just would, as one representative example, show you this study from Scotland, where they actually followed over 50 years patients that had chronic asthma or wheezy bronchitis already in childhood at the age of 10 to 15 years, and were actually then followed through different age period until the age of 58 to 64 years. At that age, they had 330 participants, 40 with chronic asthma, 53 with wheezy bronchitis, so in a way viral wheeze, and 240 controls. And what they found in a multivariate analysis, that actually COPD in the old age was associated with childhood asthma with a relatively high odds ratio, but it was also associated with viral wheeze with a lower odds ratio. And that's actually interesting that these two different phenotypes actually were associated with later airway disease. What they particularly found is that reduced airway function had an important role in you know, in actually this transition from infancy to adulthood, and particularly also the decline of lung function was associated with clinical symptoms. This was not an entirely new finding, because there was one quite impressive study already in 2003, and many other followed, where people tracked actually chronic obstructive airway disease from childhood. Here you see the age of 9 years up to adult age of 26 in children who had persistent wheezing in comparison to children who had intermittent wheezing or no wheezing at all. And you see here a lung function parameter in males and in females, and you see that the children who had actually had relatively few symptoms, they had a decline in lung function, but children who had actually persistent symptoms, they had a decline in lung function actually at much a lower level. So it seems that lung function decline has something to do with the disease process, and there's a certain tracking actually of lung function during development. And the recent, even more precise longitudinal studies have actually confirmed these findings. Now, when does that start? Does that start at school age, or does that start already very much earlier on? And one of the first studies who have actually shown evidence that maybe the infant period or even the postnatal period is extremely important. That's a study in the Lancet of 2007, where they followed actually 169 infants from the age of 2 to 3 months, where they performed lung function. This is more or less a measure of flow limitation with an infant lung function test, and they actually stratified these infants in infants who had low lung function, low, medium, medium, and high. And you see that when you follow these infants up and you use a comparable lung function test at the age of 9, 16, and 24, you see that the infants who were already bad in infancy actually remained bad all over the time. So it appears that very early on something happened that actually impairs the lung functional growth of these infants. At that time, one of the first papers by Mike Silverman and Claudia Kühne in the Lancet actually commented here, and that this is independent of atopy and asthma symptoms, and it appears that early lung development could have actually something to do with functional growth and COPD. Now, the general idea of how that people picture this is the following. You see here on the x-axis, you see age, and you see here lung function on the y-axis. Now, we all actually increase our lung function to a certain age. At the high age of 20, we actually start with our natural decline in lung function, and at some age we actually got into some limitation where we develop respiratory impairment or symptoms. But if you have some sort of disturbance of your lung functional growth very early on, your increase in lung function will be less, and if you're not exposed to any toxic substances, you actually decline naturally and you reach actually this type of limit much earlier on. So it's very possible that events that are actually induced very early in life can have a long-term impact on respiratory health in the old age. That's particularly very relevant also to all the pollutant exposure of this early infancy. So I'm actually going to focus my talk a little bit on, can we influence asthma development, and can we influence actually also lung functional growth? And that's maybe a bit of a specialized field here, but it actually should focus a little bit what we want to achieve. So our general idea of how we picture this whole complex interrelationship is that we probably all live somehow in a given environment, and we all have a certain genetic background. And from the environment, we have some triggers. They can be antenatally, they can be postnatally, they can be infectious, allergies, pollutants. There are different types of triggers, but they all may induce some sort of inflammation or injury or oxidative stress. And we probably have some mechanisms in our body that help to repair or remodel our lung. But what we have to consider that in infancy, the organ, the lung, is developing very, very quickly, and many of these the other systems, such as the immune system, also develops very quickly. And this type of balance between injury and repair actually is on the body, or is on the back of normal development. And it's well possible that this process somehow actually affects organ development. Now, in this phase where all these processes happen, we very often speak of a window of opportunity, or also a window of susceptibility, where we are particularly susceptible. But that's also opportunity in a sense that maybe we have preventative possibilities during these windows. And probably a very complex interrelationship between triggers and mechanisms that can cope with these triggers will finally actually tell us whether we develop a healthy phenotype 1 or whether we develop some sort of disease phenotype 2. Now, on Friday we will talk a little bit about the dynamics of these mechanisms, but today I would like to really go a little bit more into the question, can we modify some of them? And basically the components we have here is we can look at risk factors. Can we modify somehow the impact of these risk factors, or even prevent some of these risk factors? Can we modify epigenetic factors, environmental factors such as pollutant, tobacco exposure? Can we do something with nutrition, nutrients? Breastfeeding has been discussed quite a lot. Allergy avoidance, allergy immune therapy, there's a lot of studies on this. Can we modify the microbiome, the microbiota? Can it change somehow in lung development or in lung function? And I'm not going to talk very much on virus infection, because this is the place here who does research in that, so I'm actually not daring to speak about virus infection, but they're definitely playing a very important role. Now, can we modify these trajectories by influencing inflammation? Are there treatment approaches that are actually successful? Now, what we know from the literature, and that's actually very well summarized in this very recommendable paper by Dirkie Postma in the Lancet 2015, that there's a very large variety of host factors from epidemiological studies that are actually predisposed to later asthma and COPD. Definitely a family history of chronic obstructive airway disease, atopy, but also low lung function at birth already. Bronchial hyperactivity at birth is associated with later asthma. We do know that prenatal and perinatal factors, such as prenatal exposure to environmental tobacco or air pollution, have a role. I will show you some of our own data, but very important also prematurity and intrauterine growth retardation, cesarean sections have influences on lung development. Also, early postnatal and preschool factors have been shown now to be very relevant for the development of asthma and impaired lung growth. Nutrition, obesity, catch-up growth, these are issues that came up, and I know that there's also a very important research group here looking at these problems, and for sure, chronic inflammation. Now, if we sort of try to group and understand these risk factors, we probably come to somehow two categories. So if we start with inflammatory airway disease, wheezing disorders in early infancy and childhood, and if we want to link it to chronic obstructive airway disease later on in the elderly, then probably we have a certain group of factors that are actually related to innate or early acquired factors which impair lung structural and functional growth. And maybe we have another group of factors that are probably more related to something like innate or early acquired factors which lead to impaired inflammatory response, epithelial dysfunction, or immune development, or allergy, let's call it. So they're basically probably sort of two main groups. We definitely have some sort of an genetic background, and we have environmental triggers. And these environmental triggers can actually happen at different ages. There will be very clearly an interaction between these two main pathways. Now, to make this slide a bit more complicated, and I will actually continue making it more complicated during my presentation, I would like to focus first on something very, very simple, but we actually always forget how important this is: the in utero environment. The in utero environment is not only influenced by genetic factors, but it's also, we do know that in utero, inflammatory processes, in utero, oxidative stress triggers can actually impair the development of alveoli, airways, and vessel. And one of the strongest trigger actually is prematurity per se. And I would like to show you just a few slides on this. Why is there a connection between inflammation and lung growth? We do know that many of the pro-inflammatory but also pro-fibrotic processes are mediated by, for example, TGF-beta or VEGF, but the same substances, the same cytokines have also a role in normal lung development and branching in utero. So one of the big factors that can disturb normal in utero growth is really prematurity. And you see here some slides from a very old paper of an infant born prematurely. This child here has been born with 24 weeks. But if you look here at a histogram of a healthy control at the age of 11 months, so that's far actually after term, with a child that has actually been grown at 24 weeks and is now 14 months. So they have actually the same age, the same corrected age. This child has developed something that is called chronic lung disease of infancy, which is maybe a little bit similar to what we know from the adult world as COPD. But as you can see here, we have very large alveolar spaces with very cell-rich septa. And you can imagine that actually in such a lung, it's quite difficult to have an appropriate gas exchange. Now, if you look at the normal lung development, and you see here the canalicular stage, and you see here the septi forming, and you see here very nicely the alveolar stage, it reminds us very much, this picture reminds us very much actually at pictures of the lung really at this age. And one of the hypotheses really is at the moment that premature birth somehow interrupts normal lung development at the time when the child was born. So many of these infants have actually very early on an extremely interrupted alveolar, airway, and arterial retardation. And that will actually keep on, and that's probably one of the entities you adult physicians will actually see in probably 40 years. A lot of these children will actually come maybe with an early form of chronic obstructive lung disease, possibly, but we do not know. Now, other factors that have actually a large effect in utero are actually pollutants. And so these pollutants, they can act antenatally and postnatally. And it has been known since a long time, and I show you some of our own data of our healthy birth cohort, which is now involves now over 800 healthy children, which we followed up very, very closely. Here in 2006, we actually looked at children who were exposed to maternal smoking antenatally, and we followed then the symptoms up in the first weekly in the first year of life. And you see here compiled the first 3 months of life, the second 3 months, third 3 months, and fourth 3 months. And these are the confidence intervals of the risk ratio for infants of having respiratory symptoms if the mother smoked. And you see actually the effect of prenatal smoking actually more than doubled the risk of having symptoms in the first year of life. And the effect of antenatal smoking faded away. But if the mother actually continued smoking during this phase, then actually the risk remained. So the antenatal has a sustained effect even in the first year of life. That has actually been studied in many studies now, and very nicely summarized here also in the review of Dirk Postma. There are actually quite a lot of influences throughout entire life where actually tobacco smoking does impact lung function. You see here, for example, a child that has no risk grows up, increases lung function, and then it declines with age. But on the other hand, if a child has been exposed antenatally during early childhood, and that the patient has actually continued smoking after that, then the decline, not only the raise but also the decline of lung function is actually prominent through the entire life. There's one recent study which is surprising. Actually, that's a study from the Sapaldia. It's a big population, air pollution exposure population in Switzerland, where they have actually looked at childhood risk factors that should predict the decline in lung function in later age. And interestingly enough, smoking mothers was still an issue, older mothers. And interestingly enough, obviously virus infections also seem to play a role. So if infants were born during the winter time and very early exposed to viral infections, the decline of lung function was actually faster. So it looks like that very early factors can influence the trajectories of lung functional growth throughout life. We also do know from a lot of, or not a lot, but some epigenomics studies that tobacco can actually really induce methylation in a large number of genes, and there are several studies showing that it has been an association with allergic disease and childhood asthma. Now, we were probably very early or the first to show that actually also air pollution during pregnancy can affect lung function shortly after birth. And as you see here, we developed novel methods where we can measure lung function in the unsedated infants already at the age of 4 weeks. We can actually measure flow, we can do washout curves, we can measure ventilation inhomogeneities, we can measure nitric oxide, O2, CO2, tidal breathing, so a large variety of lung function tests. And just as a representative example, this is minute ventilation measured in a child at the age of 4 weeks, before they had any sort of viral infections. And it was actually related to PM10 exposure during pregnancy. And you see, particularly here in the 3rd trimester, you know, by increased PM10 levels by a given unit, we had a significant increase in minute ventilation in these infants after birth. And all of you who are very familiar with air pollution studies can actually say that, you know, even low air pollution levels have a pretty significant effect on these infants very early on. Now, can we do something? Can we improve air pollution and somehow make it better? And indeed, there's quite a very nice study recently published in the New England Journal of Medicine from the US. They showed actually that in the Californian area, they had a natural decline of air pollutants in many different cities, as you see here over this time. And they actually compared lung functional growth in these time periods with high and with low air pollution exposure. And you can actually see that the children that had at the time where air pollution exposure was high, they had a decreased lung functional growth over between 8 and 16 years. But when actually air pollution improved, then their lung functional growth became better. So it seems that we can do an intervention to improve lung functional growth in children. Now, can we somehow modify lung functional growth by changing nutrition? And to understand this, that's a very complex thing, and the specialists between you who know the relationship between nutrition growth and lung growth will know that there are a multitude of links between these two systems. But one aspect that has not pointed out very well so far is that probably also the mechanical stress may play a very important role, and there's very important work coming from this place actually showing that shear stress may actually activate non-inflammatory remodeling. This is a paper that's probably very well known to you, and I like this paper a lot, coming from Professor Grange here. And I actually particularly liked his discussion where he pointed out that the lack of focus of controlling airway caliber may explain why daily inhaled corticosteroid therapy has not been shown to modify the natural history of lung function changes in preschool age and school children in long-term prospective interventional studies. I think this is a really interesting and very, very valuable hypothesis. I don't think it has been proven yet, but I think this is really a point we should consider in the future. Now, there have been studies on birth weight and on growth increase in weight gain in very early on, and the impact on asthma development and changes in lung function. And this is a study we participated also, which collected several birth cohorts in Europe, altogether 25,000 children. And they actually looked at two things: one, at low birth weight, as well as at rapid first gain in the first year, so a rapid change in gain weight. And you see that both factors actually were associated with a higher risk of asthma and change in lung function. So it appears that weight gain is an important factor. That has also been observed in obese patients, and that's an interesting study, observational part of the CAMP study, where they looked at 770 mild asthmatic children. Some of them, they were non-obese at the age of 5 to 12 years, and they were followed up to the age of 20 years. And 151 children became obese with a BMI of more than 30, so that's quite remarkable. And they showed actually a significantly decreased FEV1 and FEV1 FVC. So it appears that obesity per se somehow does also affect lung functional growth. Whether this is reversible or not, it's not very well known to my knowledge. And also it's not very well known how interventional trials in obesity in childhood need to be designed in order to be effective. I mean, a lot of studies, and this is just a summary, we have tried to summarize the literature. I mean, a lot of studies speak about, improving exercise capacity, improving asthma control, so the multidimensional approach, which we have heard this morning, psychological well-being, reducing obesity. But as you see here, all the points where we have italic writing, we have not enough evidence actually that this is really the way to go. But there's a long path how we should deal with these children with asthma and obesity. Now, breastfeeding is another interesting aspect we should look up. It's well known that breastfeeding, and we showed it in our course as well, particularly in the first year of life and particularly in the first 6 months of life, have a protective effect on respiratory symptoms, particularly virally induced respiratory symptoms. We have not found in our cohort that respiratory symptoms that were attributed to air pollution exposure were actually attenuated by breastfeeding. But what has been shown by Claudia Grüne's group in the Leicester cohort, that children who were breastfed and followed up to the age of 6 years, they actually did not have, in general, a better lung function. But if the patients were stratified in children from asthmatic mothers and children of non-asthmatic mothers, obviously suddenly they saw a difference. So it appears that it's not only one factor, breastfeeding, let's call it an environmental factor, but there seem to be also some sort of intrinsic factor that need to be involved, that breastfeeding has a protective effect on lung functional growth. So you see here, these are children that are non-breastfed, children that are breastfed less than 3 months, 4 to 6 months, and more than 6 months. You see here there's actually quite a significant relationship. Now, if we look a little bit into this interaction here, so inflammation can impair lung function. We all know that. We know that that's one of the major mechanisms actually that lead to changes in airway physiology and airway structure. But when does it happen? Is it happening already at the age of 1 year, or is it happening later? And there has been some very nice work from Andy Bush's group, Seifal Saglani, published in 2005. A very nice paper, and they compared actually symptomatic infants with bronchial reactivity, symptomatic infants without bronchial reactivity, infants with normal lung function, school children with difficult asthma, school children without asthma, and adults without asthma. And you see here that the reticular membrane thickening was actually pretty normal in all of the infants, even if they had, even if they were symptomatic. And only in school children with difficult asthma, we actually found some evidence of remodeling. So the process seems not to be very early in the first year of life, but may actually, it may need actually a certain time of inflammation that this type of remodeling things occur. Now, what they describe actually in children with severe asthma, that they find epithelial damage, increased airway, areas of mucus glands, higher number of fibroblasts and collagen deposition, reticular basement membrane thickening, evidence of angiogenesis already in childhood, and particularly in severe asthma with persistent obstructive pattern, they showed increased airway smooth muscle. Now, how about the infants? What's happening with the infants? And I would like to show you one study which I have actually done in my PhD time with Mike Silverman. Some of you may know actually Mike Silverman still. What we try to see whether we find some physiological evidence that airway wall mechanics, are somehow altered. And we did a very not simple experiment. It was actually very, very tricky to do, but maybe you have to be a musician to understand the principle of this. So if anybody of you actually plays the soprano sax, then you know it has about the same length as an oboe. But the sound is completely different. So the sound, the frequency of an instrument depends on the length of the pathway, a little bit on the on diameter, but mainly on the length, but very strongly on the mechanical properties of the walls. So if you have a very floppy tube, you have very different airway wall mechanical properties. So we use this by applying, we let the infants through a mask breathe through a propeller. And this propeller actually induced pressure waves, pressure pulses onto the airway, and they started to ring. And they were ringing at a certain resonant frequency. You couldn't hear it, but it was around, this resonant frequency was here about 250 hertz in infants. And what we actually found in infants who were asymptomatic, but had a history of recurrent wheezing disorders, even if they were asymptomatic, their resonant frequency was at a very different frequency than when they were healthy. So it appears, although they are not symptomatic, but somehow the mechanical properties of their airways was different. Now, can it be actually that there are other factors, pre-existing, innate or early acquired factors, which impair lung structural functional growth, genetic factors that could play a role before actually we have any sort of insult from viral infections? And I was thinking my entire career about this, and recently found some quite interesting evidence I would like to share with you. So are there any sort of pre-existing variation in airway function in healthy subjects? You may actually know some of our work where we look at fluctuations of daily lung function. So as you can see here, you have here days and you have here twice daily lung function, and you see that actually lung function is not always the same. It actually fluctuates quite a lot, and it looks sort of erratic. But in fact, actually, there are intrinsic mathematical properties that show very weak correlation in these peak flow series, and that give us actually the opportunity to describe the stability of this type of lung function changes. Now, what we have done is we have actually we wanted to know in a very large cohort of healthy children, healthy and asthmatic children, from the so-called EPHRAIM trial. That is a trial which was done in Germany together with Erika von Mutius, of children living in the countryside, living on farms, but also living in a city environment. We actually recorded in these children at the age of 6 years, twice daily lung function for 1 month in an electronic recording. And we actually tried to see whether how their fluctuation pattern, their natural fluctuation pattern is. And we wanted to know, can we somehow categorize in an observer-independent manner, can we cluster, these sort of fluctuation patterns? So this is an example. These are six children. So this guy has lung function that sort of changes over these months like this, and this guy actually has lung function that changes over this. And what we wanted to do is, we wanted to see whether we can, in an observer-independent method, cluster these, so that that children with similar sort of pattern of lung function go into one cluster. And we wanted to describe these clusters. And indeed, that paper is now published in Thorax. we found actually several clusters. And how did we actually analyze this type of lung function? So let's assume we have one child that has lung function fluctuations like this. If we plot FEV1 as a histogram, so basically we look how many have a value of this size, how many have a value of this size. So we get a certain distribution of lung functions. And this other child here has maybe another distribution. And how can we sort of, how can we discriminate, or how can we measure the distance between these distributions? And that's actually a fairly common problem that is well known in astronomy. In astronomy, they use these techniques, and that's this technique is called Earth Mover Distance Method, where you can actually compare or measure the distance between two distributions. And you can picture it very simple. Basically, consider this is a pile of sand, and you have a worker here that shuffles. And so how many times do you have to shuffle to actually get from this pile of sand to construct this pile of sand? So that's the distance between these distributions. And we use this distance actually to cluster our patients. So that was our cluster vector. Now, indeed, we found really 4 quite distinct clusters. And we actually used a method, a hypergeometric test method, to see whether one of the clinical properties is overrepresented in one of these clusters. And you see basically cluster 1 and 2, they do share some patterns of asthma. You know, asthma definition, mainly non-atopic, bronchodilator response, inhaled characterisation. So these are mainly patients with asthma. And these 2 groups are probably mainly patients that are healthy. Interestingly enough, we actually found not only this, but we also found that cluster 1 and 3 had a relatively reduced mean FEV1, also this healthy cluster, and a relatively low coefficient of variation, whereas cluster 2 and 4 had a relatively low normal mean FEV1 and a high variability. So it appears that not only in the asthmatic group, but also in the more or less healthy group, there are sort of different patterns of lung function behavior or lung function fluctuations in these children. And interestingly enough, in this cluster 3, 80% or 85% of all the children had actually a genetic variation in 17q21, which is one of the interesting genetic signs for us. So it appears that it could be that we have also some functional pre-existing conditions that make us more susceptible. Now, if we have if we actually want to know, can we somehow influence this whole balance, then we probably find substances that are protecting and some factors that are actually enhancing this type of balance. And I would like to focus a little bit on these protective factors. And there have been quite a lot of studies actually looking at specific diets or nutrients on lung functional growth. And there are actually over 130 trials, and they have very nicely been reviewed recently. All of these actually show no or very, very small effects. I mean, we do know that maternal diet during pregnancy have very small, if at all, effects on lung function at school age. Also in probiotics, there are no sort of stunning, very convincing effects. Same is true for these. Vitamin A and E supplementation has been shown in a very specialized population that it has an effect. But there are 2 studies here that are interesting to look at. One is very recently published by Biscard et al., and they looked at long-chain polyunsaturated fatty acids in fish oil, and they actually examined 2 groups of offspring of mothers that had over 24 weeks a 10-fold dose of fish oil during pregnancy. And what they actually showed that the risk for asthma or persistent wheeze in the fish oil group was lower. But in fact, also on lung function, there was actually no significant effect. Now, a lot of studies have actually also looked at vitamin D at school age, and there's quite a lot of literature, as you see. And so a recent meta-analysis of 16 studies showed an inverse relationship with asthma and WHEASE, but there's in none of the studies really a reproducible effect on lung functional growth. And 3 recent RCTs have actually either shown non-significant trends or negative effects. So also here we have not like a major possibility to intervene. Allergen avoidance, allergen immune therapy, that's very sparse literature, but there is a very nice systematic review on this. No studies showed no effect on lung functional growth. 3 studies showed a very small effect on lung function, but there are really no long-term observation of allergen immune therapy. Allergen avoidance, there is one study that we were all very impressed from Manchester a couple of years ago. They found an effect on lung function by allergen avoidance during pregnancy. But if one really looks at the data, then it's actually only a subgroup of 32 toddlers that actually showed an increase in airway resistance. And all of us who have done lung functioning in 3-year-olds know that this is really a difficult task to do. So I also, in my view, we have not enough evidence to really say that allergen avoidance has a sustained impact on lung functional growth. Can we modify microbiome and change lung functional growth? There's actually not much long-term data on this, to my knowledge, but maybe you know more about it. But there's one study which Oliver Fuchs has done, one of my former PhD students, who we worked together in the Gabriel Ephraim cohort in Munich, where we actually looked at the lung functional growth as well as the FeNO in children who were exposed to farm. So that's actually a very high diversity of microbial diversity. Children who were exposed non-farm children and unexposed non-farm children. And it looks like, you know, the overall population did not show any signal. But if one stratified in the children with atopic sensitization and children with without and with atopic sensitization, we see in the group without atopic sensitization really no effect of the environmental microbiome on the FeNO as well as the lung function value and the lung functional growth. But what we see, if we have a predisposing factor here in the atopic group, that we have a certain effect on FeNO, and we have a very tiny effect on lung function. So it means probably that we do need some sort of underlying process to really have an impact on lung function. Now, can we modify inflammation very early on? And you all probably know this very nice study, and there have been others following, but that was probably one of the most impressive first studies. So this is a multi-center placebo-controlled parallel group trial of 258 preschoolers at the age of 3, and they had asthma since the age of 1 year. And they were all on a combined therapy with fluticasone and placebo. And you see here that during the treatment phase, actually the children had a higher proportion of episode-free days than the placebo, the fluticasone group, but this effect actually faded away after quite some months. The same is actually true for lung function. So there's no sustained effect of early treatment on lung function, and I believe that we have so far no real evidence that treatment with anti-inflammatory medication early in childhood really does somehow change the lung functional trajectory in preschool age. So, if we summarize, that's a hard fact. Obviously, symptoms and lung function decline are related, and but probably the interaction is not so simple. There may not be one single factor that actually causes it, and also the role of viral infections is probably more important than we think. I would not like to talk about this, but as a pediatrician, you know, from my clinical experience, I mean, I can very much believe that viruses early in life can have a tremendous effect on lung structure. I mean, you do know, all know bronchiolitis obliterans after, for example, a viral infection in the first year of life. You probably know how ill these children really are. So I believe that viral infection may have a very important role here. So in conclusion, there's probably no single mechanism leading to impaired lung functional growth, and the effect is rather caused by the interactions within a network of involved subsystems. Many of these subsystems effects are small, and their effect size can be age dependent. And some factors act directly on lung growth, some indirectly via chronic airway inflammation, and some even via shear stress and airway remodeling. But what's probably very, very important is the environmental interaction at a given time point. We do have some factors that act as enhancers or protectors, also with probably small effect sizes. But what we know for sure is that we do have some low-hanging fruits to ensure appropriate lung functional growth. And these are preventative measures. I mean, if we can prevent prematurity, for example, better, then we can actually have a very large impact on a large number of young children in terms of their lung functional growth. If we can reduce smoking, if we can reduce air pollution during this early and exposure in these early ages, then we probably can do a lot. And also appropriate nutrition and appropriate asthma control are probably very, very likely important, simple measures to ensure that these children can, their lungs can grow appropriately. Whether anti-inflammatory or anti-inflammatory and anti-obstructive therapy is needed in preschool age, I think this is quite a nice question, and I would love to see some data of that. So if you once come to Switzerland and if you once find your way to Basel, this is our brand new hospital and it's really nice. So please come.
Thanks very much, Urs. Fantastic talk and very thought-provoking and very comprehensive too. So we have some time for questions. Is that right, Steve? 10 or 15 minutes? Yep, so if there is any questions, yes, Guy. Yes, that's right. So for the online audience, people looking online, if you type in the question, then Steve can transmit the question to us. Sorry, Guy.
That was great. Tremendous widespread of stuff. It's very interesting to me. I wonder if you could show that slide again with the cluster analysis or the phenotype analysis. That one, yes. I guess it's interesting. One of the complexities of this observational analysis is the nuisance that treatment is. Treatment is a real variable. We wish people didn't take treatment. We like to be a hell of a lot easier. But looking at this, I just wonder if the difference between cluster 1 and cluster 2 is not simply that the people in cluster 2 were on treatment and the people in cluster 1 had steroid treatment and the people in cluster 1 were not on treatment. And are they actually the same? Because you said this may be evidence of pre-existing differences.
Yeah, I can.
I'm wondering if, in fact, cluster 1 and cluster 2 would not otherwise have been the same apart from taking the treatment.
I think this is an extremely important question, but we actually knew this question upcoming already when we designed the study, and none of these children actually had treatment during this 1 month of observation. So that actually we would not know how to deal with the situation when they were on treatment. So they are really mild asthmatics, and they were not on treatment during these months. Yeah.
So what does that thing at the bottom then mean?
They have a history of using inhaled corticosteroid and having used bronchodilators. Yeah. But on the measurement period, they were not on treatment. Yeah. We had actually first 3 children that were on treatment, but we excluded them exactly from the analysis for this reason. Yeah.
Question over there.
Because I was really stunned by the precipitous drop in lung function in the neonates that took steroids in their first year of life and then went off and their lung function dropped away.
Yeah.
It looked like they were actually going to overtake and have worse lung function than the non-treated kids. Do you have any idea what's going on there? What's triggering that precipitous drop? Is that just poor protection against virus infections, or do you have any thoughts about that?
You're talking about the preterm infants, or the preterm infants?
The peak study.
Yeah,
the peak study. Okay, but these are children with asthma type of symptoms. I mean, these were the number of symptom-free days. So, and I mean that's the group. So probably with the confidence interval, you may actually end up in a sort of quite a large overlap. So I would not dare to say that they are going under that. But I think for me the main message is that the effect is not sustained. It sort of goes back to the others in after a certain time. Yeah.
I just want to make a comment on the decline in lung function as well. Apart from the one you showed in early childhood, in Durkee's Lancet review, in that diagram you showed, at the other end, which is what I'm interested in, the 50 plus, the ones that had low lung function had actually appeared to have a more rapid decline in lung function beyond the age of 50. And perhaps that really explains why we see much more airflow obstruction associated with asthma above that age. Yeah. And I'm starting to believe what you pediatricians say, that the origins of obstructive or worsening airflow obstruction might actually be very early on.
Yeah, yeah. It could be that sort of a bow from infancy to later on.
Yeah.
Yeah.
Yes, Bruce.
I'm really interested in your asthma obesity story at the beginning as well. There was a paper published in the Blue Journal earlier in the year, and I think you contributed data to it on obesity and airway dyssynesis and how those people lead to asthma. So in terms of the airway dyssynesis story in children and how that potentially can lead to the condition of asthma, whatever that means.
Yeah.
But I'm interested in your thoughts.
I mean, I did not contribute to this at all, and to be honest, I have a bit of a systemic view of the interaction between obesity and asthma. We tried to sort of picture that as a hypothesis in this paper in allergy. I mean, there's actually evidence that they share common environmental factors. They share common behavioral factors. They share common immunological genetic factors, like mechanical factors. So basically, we have two complex subsystems. And if you have one subsystem that is somehow altered, there will be some connections through a multitude of different pathways that will influence another network of a complex disease. And I don't think it's one mechanism. I think it's a multitude of different mechanisms where sort of one network influences another network. So that's my sort of view of how this is. I think it's extremely complex. That actually also would support somehow the hypothesis that has been stated early in the morning, that we probably need a multi-dimensional approach to really address these sort of complex issues.
I might throw in another question too. Your last conclusion is that we do have some low-hanging fruit, and you included effective bronchodilation or maintaining airway caliber in children to perhaps lead to better long-term outcomes. Why do you think the studies so far have been negative in that regard?
I mean, I think it's exactly what is stated in your paper. That majority of the studies are based on steroid treatments. I mean, in my view, there's really a lack of a study that's showing steroid plus a very good long-acting agonist over a certain period does actually change something. But it has partly also to do because we have not used long-acting beta agonists very much in preschool age because there was not enough evidence. But I mean, last year there was this study from Stempel and colleagues that actually showed that it's safe in children and that we can use it actually probably a bit more easy.
My impression when talking with my pediatric colleagues is they're feeling negative in terms of the ICS-LABA combination in children. I presume that's based on those negative long-term outcomes.
I think it's actually based on the lack of evidence that it's active and safe, but I think it has changed last year, that we have more and better evidence. Yeah.
Oh, sorry, Peter.
So, do you think we have any bronchodilators that work in children under the age of 3?
Oh, yeah. I mean, in my daily life, I use a lot of bronchodilators. I mean, we do know that, you know, I mean, short-acting agonists do work, but not in all of the patients. And I mean, the classical group where we have difficulties to see an effect is children with bronchiolitis, you know, RSV bronchiolitis, because there we probably have a lot of mucus plugging, we have a lot of hyperinflation, we have probably a very poor deposition, and what we sometimes observe in the children that they even desaturate after the ventilating, because we have a lot of you know, ventilation perfusion shifts, and so what we actually do in our practice is we have a try. If it doesn't work, we stop it, because it also increases, you know, your metabolic rate. It increases in small children, you know, their reflux tendency, and so we have a try. But some of them, they react. I would say probably 30 to 50% react. But the worst ones, they go very badly. But I mean, some go very well. Yeah.
Was there a remote question, Steve?
Yeah, so there's a question here. What are your views on the potential of a clinical application of helminth or hookworm proteins to modify lung development?
The potential of what?
Hookworm or helminth.
Okay, I've unfortunately no experience with that. I can't say anything about it. I'm sorry. Yeah.
John.
So, if you went off to a public health authority,
yeah,
in terms of what do we know? What are the things that make a difference? Prevention of premature birth, reducing smoking during pregnancy, optimizing appropriate nutrition, avoiding obesity. They're going to come back and say, well, look, they're things that we know about this anyway. We're trying to do these things anyway. Is there anything specific from a respiratory point of view that the lung research community can say, look, we've got something that public health authorities do not know about already that's going to make a difference to these kind of outcomes?
I mean, you know, we see, you know, all of these factors are important. You know, I mean, prematurity, what we have seen actually, and that's something we have done in Switzerland now, we have really looked at the outcomes of the neonatal units. And the outcomes of the neonatal units, they are very strongly dependent on the experience of these people. And we see now that you know, the rates of chronic lung disease of infancy actually in the last 10 years really went down like this, because you know they ventilated with lower pressures, with less oxygen, you know, nasal flows, and that made a big difference. Also, I think it's you know, the prevention of tobacco smoking in young women is something that unfortunately has a bit increased in the last couple of years, at least in my environment. But that's something also we should keep on preventing. Air pollution is just I mean, that's my standard thing. You know, I want air pollution go down and down. And in Switzerland, it's really, we see this trend. We have actually really reduced air pollution a lot in the last 10 years. Yeah. We have, in some of the, you know, from our lung function measurements in infants, some of the effects we have seen 10 years ago, we do not see anymore now, because the pollution levels went down, but they were not sky high anyway. Yeah.
Peter Gibson had a question.
Thanks, Urs. So, asthma exacerbations during pregnancy are a major risk factor for low birth weight babies.
Yeah.
And they can be easily modified by inhaled steroid and long-acting beta agonist during pregnancy. I'd just be interested in your comments about that as a lowering.
No, I'm absolutely agree with you. I think it's a very, very good preventive measure, and it was just not sort of my topic, but I'm absolutely agree. That's a very important thing. We always forget. I mean, I think pediatricians should speak more to obstetric people, and I think this interaction should be much more closer. I fully agree. Yeah.
Thanks. Well, I think we've reached our 2 o'clock limit. So I'd like to thank you again, Urs, for a fantastic and really thought-provoking talk.
And thank you to our online audience for tuning in.